Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Predictors of Specialized Pediatric Palliative Care Involvement and Impact on Patterns of End-of-Life Care in Children with Cancer, by Widger et al. My name is Erica Kay, and I am an assistant member on faculty at St. Jude Children's Research Hospital in Memphis, Tennessee. I am dual trained in pediatric oncology and hospice and palliative medicine, and I specialize in the provision of pediatric palliative oncology. Over the past decade, we have seen a growing collaboration between the fields of oncology and palliative care. In the context of adult oncology, a series of studies have shown that patients and families who receive palliative care concurrent with cancer-directed treatment experience clinically meaningful benefits, including improvements in quality of life, psychosocial outcomes, and survival, as well as reductions in caregiver stress and adverse sequelae secondary to complicated bereavement. In the context of pediatric oncology, palliative care involvement has been associated with improvements in symptom control and enhancement of self-reported quality of life by patients and families. However, relatively little is known about the impact of specialized pediatric palliative care teams on end-of-life care patterns for children with cancer. To my knowledge, the study by Widger et al. Is the first to harness data at the population level in an effort to better understand the value of specialized pediatric palliative care services for children with cancer at the end of life. In this manuscript, the authors' specific aims are twofold. First, they endeavor to describe the subpopulation of children with cancer who receive specialized pediatric palliative care services. Second, they attempt to quantify the impact of specialized pediatric palliative care services on the likelihood of receiving high-intensity medical care for children with cancer at the end of life. To accomplish this goal, the authors designed a retrospective cohort study utilizing population-based data from a childhood cancer registry in Ontario, Canada. All children with cancer in the province who received care from pediatric centers with a specialized pediatric palliative care team and who died between 2000 and 2012 were included in the cohort. The authors further stratified the cohort into those patients who received services from a specialized pediatric palliative care team, those who received general palliative care, and those who received no palliative care. Receipt of general palliative care was defined by the abstraction of two or more diagnostic or billing codes related to palliative care in the patient's medical record, in the absence of formal services provided by a specialized palliative care team. No palliative care was defined as the absence of specialized or general palliative care within the 30 days prior to death, in an effort to clearly delineate the exposure from the outcome. Patients within each stratum were linked to population-based data regarding medical care received in the inpatient, outpatient, and emergency department settings. The authors selected intensive care unit admission within 30 days of death as their primary measure of high-intensity end-of-life care, a metric that is substantiated by the literature. Secondary measures included mechanical ventilation within 14 days of death, in-hospital death, and a composite measure extrapolated from the adult literature that incorporated data related to administration of systemic chemotherapy and/or inpatient hospitalization within the last month of life. A total of 572 children with cancer were included in the cohort. 29% received care from a specialized pediatric palliative care team for at least 30 days prior to death. Nearly 18% received general palliative care, and slightly more than half received no palliative care during the last month of life. The authors conducted univariate logistic regression analysis to identify significant predictors to include in the multivariable model. They found that involvement of a specialized pediatric palliative care team was significantly less likely to occur for children with hematologic cancers and for those who lived in lower neighborhood income quintiles or at greater distances from their tertiary center. Notably, they also found that involvement of a specialized pediatric palliative care team was associated with 5-fold decreased odds of intensive care unit admission, while receipt of general palliative care had no impact. Similar associations were found with all of the secondary high-intensity end-of-life care indicators previously described. From these findings, the authors primarily conclude that, when available, specialized pediatric palliative care services are associated with lower intensity care at the end of life for children with cancer. Importantly, similar findings are not seen for children who receive general palliative care alone. Overall, this manuscript is highly relevant to the practice of clinical oncology in the context of the growing field of pediatric palliative oncology. Perhaps most compelling is the differential impact identified regarding the provision of specialized pediatric palliative care services versus general palliative care. These data provide tangible justification upon which to build advocacy efforts for creation and expansion of specialized pediatric palliative care teams and programs in pediatric cancer centers across the country and world. These findings are also immediately applicable to clinician training and educational initiatives that aim to improve overall clinical care for children with high-risk cancer. As this study reveals, even within pediatric cancer centers with formal palliative care teams, less than 1/3 of children who die receive services from specialized palliative care experts. Given the demonstrable benefits of specialized palliative care involvement for children with cancer at the end of life, institutions should consider a two-pronged approach towards improving end-of-life metrics for pediatric oncology patients and their families. First, institution-wide educational initiatives should be designed and implemented to improve provider awareness and mitigate stigma associated with referral of patients to specialized pediatric palliative care teams. The literature suggests that lack of standardized palliative care education for pediatric oncologists is one barrier to palliative care referral for children with high-risk cancer. A variety of cancer-specific pediatric palliative care training models exist for clinicians, and didactics should be offered on a semi-regular basis with institutional incentives provided to enhance attendance. Second, institutions should consider the value of automatic palliative care referrals for select high-risk patient subpopulations. The literature has shown that individual clinicians may harbor biases, whether conscious or subconscious, which preclude or delay patient access to specialized palliative care services. Certain subgroups, notably patients with hematologic malignancies, have been shown in this study and others to receive less access to palliative care as compared to patients with solid tumors. A priori identification of subgroups of high-risk patients and families who might benefit from specialized palliative care services effectively circumvents provider-specific preferences and biases, thereby allowing for more equitable distribution of resources and services. For example, at one cancer center, all children expected to undergo hematopoietic stem cell transplantation receive formal referral to a specialized palliative care team as part of their pre-transplant evaluation process. I would emphasize, however, that not all centers have equivalent resources and needs, and institution-wide collaboration and consensus is essential in the process of developing and piloting an automatic referral process. Lastly, I would like to highlight the valuable research opportunities generated by the findings of this study. In the context of compelling evidence to suggest the need for more frequent and earlier integration of specialized pediatric palliative care services in the care of children with cancer and their families, further investigation is warranted to better understand how the timing of palliative care integration affects end-of-life experiences and outcomes for patients and families. The authors also propose several strategies for optimal integration of formal palliative care services into routine pediatric cancer care, presenting embedding and parallel involvement as potential paradigms. Rigorous investigation is needed to determine the feasibility, acceptability, and impact of early integration of specialized palliative care within the field of pediatric oncology. It is important to identify several limitations of this study, acknowledged by the authors, which include the biases inherent to a decedent cohort design, as well as the inability to account for patient or family preferences or goals of care. Additionally, it is worthwhile to note that the author's methodological decision to classify those patients who received specialized palliative care services exclusively during the last month of life as no palliative care is not necessarily reflective of their experiences and may confound findings in the context of a stratified analysis. Lastly, the authors are wise to acknowledge the inherent differences between the Canadian and American healthcare systems that might inhibit the generalizability of these findings outside of Canada. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.